Mr. Keneally was my first ever SPR when I started surgical training, and I suppose it's kind of gone downhill from there. I'm delighted to be here. It's really a huge honor and privilege to come to the matter. I really look forward to seeing your fantastic new setup and to learn a little bit more about traumatology, how it's evolving in Ireland. I really had no idea what I was signing up for. That's acute care surgery. Thank you for coming to my TED Talk. There is such vast complexity. I started out thinking I was going to be the county surgeon in Wexford. I was going to be Ken Mealy. I was going to be Bosco Mahoney. And then it developed an interest in surgical oncology through starting out interning in Connolly with John, with Tom Walsh, etc. And then the most extraordinary thing happened was that finding myself on call for general surgery and in Connolly, where there was a spate of violent injuries around drugland interactions at the time. And actually, I remember, I don't know if Mr. Barry is here this morning, or he might be online, because he was in Connolly in around the same time. And I vividly remember getting a phone call from him. I wasn't on call on a Saturday morning, and I was year intern, to say that, look, we need help in theatre. There's been 2 gunshot wounds. We're running 2 theatres simultaneously. Can you please come in? And I was the intern. And I obviously was very excited, and I came in, and I remember it was an interaction between 2 neighbours, and they had a disagreement over a parking spot, and one pulled a shotgun, discharged the gun, was turned around and shot the other fella. And initial sort of cavitary triage with the suggestion was that this was a gunshot wound to the right upper quadrant, to the abdomen. A laparotomy was performed. They could find nothing. There was no blood. Another look at the chest X-ray revealed that this is probably that the ballistic had fallen into in at the base of the lung, and the chest was opened. And this is where I arrived in as an intern without any idea of what I was getting myself in for. We proceeded to perform a lung resection to go ahead and wash out the chest, place chest tubes, at which point the very senior Sudanese registrar decided that there were other things that needed attending to, and he upped and left me there at the table with an open chest. Very briefly, obviously, and I presume it was a test, but it was really like, wow, what do I do now? What have I gotten myself in for? And that sort of has followed me throughout my career. I decided I wanted to have more experience and training, and I saw an opportunity to go to Philadelphia, because being a bit of a nerd, they had a conference on, and at the same time they had a DSTC, a definitive trauma surgical care course running. I went and attended that course with Bill Schwab, who founded Penn Trauma. And really, a love has grown since then. I've attended and taught on many of these type courses with Professor Fafard from Johannesburg and others. And it's really been something that has fascinated me. And so when I heard that there was the birth of a trauma system and some notion or hope of integrated trauma care for Ireland, I was incredibly excited. So much so that I couldn't advance my slides. Here we go. There we go. One of the most wonderful pieces of advice I ever got when I was doing up my kitchen was to buy 2 dishwashers. Because then you never have to put anything out of the dishwasher into the press. You have a clean one and a dirty one, and you revolve them. But another life hack that I was told was that to think differently. If you want everything in your kitchen to be dishwasher proof, then act like it is for about 6 months. At that stage, anything that's not dishwasher proof is broken and in the bin, and you've replaced it in IKEA with dishwasher proof things. And so it's a bit of a sort of an expensive kitchen utensil Darwinism, but there's the sort of the point to it really is that when you apply simple, straightforward logic to any kind of a problem, generally the soluble problems are solved very early in the process, and you're left with the difficult problems, the things that are relatively resistant to logic and the straightforward pathways. And emergency general surgery is an all-embracing term, and more specifically to building a system is very much like that, in that the dishwasher proof, the logic proof pieces are really very difficult to address and require a lot of different thought. I don't have any disclosures other than none of these ideas are mine. These are the product of many years of trial and error, mostly error, across the United States and other places where they have mature trauma and acute care systems. You saw my title slide was talking about wicked problems, and it's not to do with that awful movie. In fact, it derives from a phrase from two academicians in the US, in Berkeley, Horst Rittel, who was an urban planner, and Melvin Weber, who was his postdoc student at the time. And what started out as a paper that was largely a rant on the frustrations of urban planning and building systems and building neighborhoods and communities really resonated with me as having applicability to what you are doing here and what we have done in the States across a number of domains in creating a system. So they had a look at urgent or at wicked problems, and they came up with 10 sort of definitions of it. Firstly, that you can't really define the problem in advance because the description is based largely on the solution that you're trying to pursue. So, failure of non-operative management of small bowel obstruction, for example, is a pathophysiologic state. But is it also your own personal risk threshold? Is it a systems level problem related to delays and so on? It's how you define the problem is related to sort of the types of solutions that you go with it. You have to decide the problem. When do you stop? When do I meet my goals? There's no such thing really as the answers being true or false, but the most appropriate and correct thing in the current moment, in the current evidence. Sometimes it's very difficult to test what it is that you're doing, because it can have multiple different outcomes that have knock-on effects in different ways. Early tracheotomy in the multi-injured patient has trickle-down effects that aren't immediately apparent, but in the recovery trajectory and how we can get them back to normal state, where they go home versus other places, and so on. Often these problems are unique. There isn't a list you can bring up, a checklist of solutions. They can be interplay very much so of other problems, multiple explanations. And unlike a lab experiment or a clinical trial, you don't really have a right to be wrong. You have to work with the outcomes that you have, and you have to take accountability for the decisions you make for unintended consequences. When I talk to my American colleagues about the notion of trauma care in Ireland and the notion of emergency surgery in Ireland, where we have 26 receiving hospitals and emergency departments across the country, and then often geography describes how you get a patient, where you get them, and then ultimately the resources that are available to them. I always tell them the old joke about the road to Kinnegad, and when you ask an Irish person for directions, he starts with, well, I wouldn't have started from here. And then proceeds to give you directions based on pubs and churches. And so it's very difficult for the Americans to concept. I think I'm wandering into meme territory here, because the American mind cannot conceptualize the notion of the care, of the really high quality healthcare that we have grown in Ireland, but dispersed across different areas in a way that to them seems chaotic and non-networked, though that in truth is not the case, because we're much more high context society and we much more personal relationships. And so our care is embedded in the community we grew up in. Mr. Keneally spoke about Connolly Hospital. This is my photo from the very first day I was there as an intern. They hadn't yet put the map up. That was their ultimate intention. So the only direction I got was that I was here. And that led me to thinking about, where do we even start in terms of setting up a system that looks after arguably many of the most vulnerable surgical patients, those who there wasn't a plan or a predetermined notion for them to be there, those for whose care is very complex and multidisciplinary. And I think where we have to start, to borrow from the US Navy, unpopular and all as they are at the moment, was that the most dangerous phrase in the English language is that we've always done it this way. And it's a lesson which we learned, or was learned by my predecessors in Penn in setting up the trauma center and then resetting it up in the newer hospital, was that, you know, there is great fallacy in saying, oh, well, we're just going to set it up in the same way as we set up an elective clinic or so on. Because, I mean, that's what we know, that's what we've always done. I was putting some thought into the challenges that exist to setting up a trauma or acute care system, because when I started in faculty and finishing my fellowship at Penn, I was immediately assigned to Grandview Hospital, which is a rural hospital about 50 kilometers out of Philadelphia, because they had just set up a trauma center and hung a shingle outside the door that said, we're the trauma center, and sort of bought the sports package from Penn Trauma in terms of institutional supports and surgeons and nurses and registrars and so on that would come and help them set up a system. And so what became immediately apparent to me was, and for the mathematicians in the room, I apologize, it's not a true Venn diagram, but that there are so many competing pieces to what we think is a trauma center and is a trauma thing. You're very much controlled or constrained by the restructure and the resources, the priorities of the institution, because you're not building something from the ground up necessarily. You have to implant it on an already mature system that has ways of doing things and has been doing them incredibly successfully. You have to work with the additional capacity as well as the changes in capacity management that come with changing what your business, your core business is. You have to really get into governance. You have to figure out how you navigate the tensions between your elective and your emergency streams. How do you make sure that you're delivering quality? Who owns the credentialing of the quality? And you have to get beyond the misconception that acute care surgery is not the Hollywood notion of trauma. If you're here this morning for me to show you lots and lots of gory pictures of people with their heads blown off, then I'm sorry, you're going to be disappointed, because that's not all traumatology is. So understanding those limitations, in his book Atomic Habits, James Clear tells us that we need systems, because systems allow us to be successful on a repeated basis. And thinking about where you are and where Grandview was in setting up a system from nowhere, was that they had to navigate transitioning from a completely elective model, as was the case in their hospital, with predictable capacity, predictable resource draws, et cetera, to the notion of a center that has surges and peaks and valleys and different types of time, and a different way of interacting between us all as a group. There's a notion in health systems development that actually is sort of pulled from the machine learning and AI literature, the notion of a learning health system, that by providing multiple different inputs and processing those inputs in a sort of a micro level, that you have the opportunity to adapt the system, adapt your processes, and therefore influence your outcomes. What do I mean by that? By that, you have to, in order to set up as we did in Grandview, we received major trauma center designation, and you start off at phase 0, where somebody goes, congratulations, and shakes your hand and says, you're now the trauma center. But you receive all kinds of pushback because it's a change to the status quo, there's a change to your volume, and that hits many aspects of your hospital, but also there's a variability in terms of it's no longer the predictability you have from your previous status quo. And this doesn't just apply to acute care surgery, it applies to many pieces. I'm sure there was changes to the system when you centralized breast care, for example, and suddenly places that were doing it are no longer doing it and have a void to fill, and that destabilizes their equilibrium, and the places that are designated, the centers, have to absorb this and have to change the way they do things. There's then a phased approach to setting up a learning system, and that's that you have to make sure you know exactly what you're doing. You can't improve what you're doing unless you know what it is. You have to track and trend any delays, any deviations or complications. You have to define what a problem is. And then you have to build upon that iteratively with improvement cycles until you get to a real learning system that is able to predict signals and optimize often in real time. And we're beginning to see that in our electronic health records, where AI can give behavioral nudges to clinicians based on various signals from the patient's data and from what it knows worked well and didn't work well before. So a little bit about the background at Penn to give an idea of how it's not just setting up your shingle and saying, oh, we're now a trauma center, nor is it just bringing in personnel and expertise. There's more of a system to being a trauma center, and we've learned this the hard way over 30 years. My mentor, Bill Schwab, spoke of war being a laboratory of nightmares. More than any other recorded events in history, war has advanced the care of the injured, and we know that we're reverting to whole blood, which started in the Korean War, and then we got fractionated blood as blood banks became more common and were used for non-surgical purposes. And because in the States, blood banks are private entities and there's a commercial aspect to dividing blood, and I can charge you for some red cells and some FFP, and it's different and more than just charging you for blood. But recognizing this, the US Navy recognized what's known as, I believe, the Marshall effect, or peacetime effect, where you get skills atrophy, where you're not continually getting reps in the procedures and the cognitive processes that you use. Decided, well, in peacetime, there's really only one good way that we can keep a military trauma surgeon or trauma anesthesiologist or trauma emergency medicine physician in their peak form. And like an athlete, you have to do out of season training. And how do you do that? Well, you could start a war, which isn't necessarily a great plan. But what they chose to do instead was to embed their Navy with us at Penn, because West Philadelphia is an urban war zone. This is a graph of the number of gunshot homicides per year. since 2008. We crossed the threshold in 2020 when I arrived, unrelatedly, to 1 murder a day. These represent all murders by gunshot wounds. And as our South African trauma colleagues here will tell you, that there is a multiplicative effect. It's like being in clinic. How many patients do you see in clinic to translate into a patient that needs an operation? Similarly, a factor of maybe 4 or 5 patients receive a gunshot wound for one of them to die. And so this really gives you an idea of the scale of the problem in Philadelphia. I just took a picture of from my phone because I get text alerts to show you the frequency of these problems as they arrive in our trauma center. And to show you the case mix, that it's not just the Hollywood gunshot wounds. There's an awful lot of motor vehicle pieces. There was a large fire in West Philadelphia 2 days ago, and so we got a lot of inhalational injuries. And so we're not a burn center, but we still have to receive them in initial triage. My colleagues will fully understand the pain of the missed triage by ambulance where patients come to your center that you're like, we're not the best place for this. We're the nearest place, but not the best place. And these are things you have to navigate as well. One gory picture. I had one gory picture of a clamshell thoracotomy, and I guess I'll be talking to some of the trainees and students a little bit more about penetrating chest trauma as I'm with you here today and tomorrow. But I couldn't have a talk without a picture because there'd be complaints back to the editor. One thing that was unique in Philadelphia, thanks to Bill Schwab, was the notion of police drop-off. So recognizing that most of the gunshot wounds were within a small radius of the hospital, and that first person on scene was police rather than emergency medical services, rather than the ambulances. He was able to create a city mandate with the police department that the normal pathway is the police hear on the radar about a shooting. They go to scene, they secure the scene. The back seat of the police car has no seatbelts in it and is angled backwards so that they can throw the guy into the back of the police car and he won't fall off into the seat well. And they drive straight to the trauma center. What that translates in is that, as happened last Tuesday night when I was on call, some guy got shot, and in other systems where the EMS would stay and play, would not have made it off the scene. I was operating on him within 6 minutes of him being shot. And that translates into the invasiveness that you see, into our very high ED thoracotomy rate and so on. And much less so into other adjuncts like REBOA, which I can chat to people about if they're interested in. So that was sort of one innovation. But another innovation at Penn was realizing that, well, we have to kind of go back to the root problem. This is Sunny, one of our nurses. She heads up one of our injury prevention programs, and has managed to secure funding to give out gun locks and gun safes and so on to the community free and charged, recognizing you're not going to, on a systemic level, address the Second Amendment rights to bear arms or whatever amendment it is, but that you can, in fact, you can accept that this is part of the culture and say, well, how can we make this safer? We also, at the distal end of it, have a violence recovery program, which we're really very proud of and is a very cool thing. So we've hired psychologists, social workers, who are all specially trained to meet the patients as inpatients at the time of their injury, and to help them with really useful stuff that's nothing to do with their health care, but is to do with trying to decrease the likelihood that they will succumb to violence again. Even little things like when you arrive into the trauma bay, the first thing that somebody happens when you're frisked is they take your ID because they want to find out who you are and match you on the computer system so we have a record. Very often the police, deciding that this is helpful to them, will borrow your ID. And you need your ID for everything. You need your ID to, to get a mobile phone, to open a bank account, to draw your, social security, to all of these things. And so they help in the background with really rehabilitating people and helping them with stuff that we never thought about. And I think that's the sign of a maturity of a system, is that you're thinking not just of the thoracotomy piece, but you got to think as well of, how do I stop this from happening again? How can I be a turkey voting for Christmas? Because ideally that's the case. And you have to invest in training. So Penn was the first place to take the 1-year fellowship, as it traditionally was, where you did surgical critical care and a bit of trauma surgery, and say, hang on, what if instead of that, we have a 2nd year of training where the 2nd year trainees are consultant surgeons and they have admitting rights and they're on the call schedule. You can see how this is an advantage for everybody. And have, senior buddy and a backup, but can, in a safe space and in a mentored space, can grow into the role of being a consultant. And they really showed that in terms of the fellows and exceptions, what they were called in the 2nd year, and they take trauma call, they take emergency general surgery, they run a team, they have their name over the bed in the usual way that any consultant is. But it found that very quickly the system is able to support them into a role that, by the end of the year, whether they stay or whether they go on to a job elsewhere, they've already been the consultants. Not that they walk into the matter for the first day and go, I don't know what I'm supposed to do. Will somebody call the consultant? Oh, no, wait, I'm the consultant. That they've done that process. It also translated into outcomes. And we found that through our PI process, there was no difference in them making the appropriate decisions. There was no difference really in technical ability compared with the established consultants, and in guideline compliance, etc. They did that. And so it really was a great on-ramp, and this, something towards, an ST8 and so on that might be considered for people who have a particular interest in acute care surgery. I wanted to share with you very quickly, and I do apologize for the over-Americanization of the video, but it's a commercial video for the center. But I wanted to give you an idea of what we're looking at. I was very lucky to be able to do this in real time with Professor Cahill, but with the distance of 3,000 miles, I'm going to show you a quick video. And I hope the sound is off, because otherwise it's very twee. I'm going to make the sound off. So the police vehicles, as I said, drive up the driveway. This ambulance entrance here bifurcates when you go inside. You turn right for the emergency department. The trauma bay, the trauma department, essentially is physically separate from the main emergency department, though there is easy flow through because we have a lot of crosstalk. Patients are taken out of the police car and come into the security area. Everybody, signs of life, no signs of life, is frisked. We do not want to have a weapon in the trauma bay. It has happened. I have been on call and been handed a weapon during a resuscitation. We go into the trauma bay. You'll see that there are 5 identical trauma bays with extended capacity at the end. Jeremy Cannon there in the grey hoodie is our Navy liaison. And we go through a very organized process that would be familiar to all of you in terms of resuscitating a severely injured patient. As we pan down the bay 5 has a link, that white camera there on the wall, to the labor and delivery ward, so that if we have obstetric patients who are injured, we can closely liaise with them. There are 2 CAT scanners in the trauma bay. And outside the far side of the CAT scanner, which has another exit from the trauma bay, is a set of lifts that takes you up to theatre. This was filmed during COVID, and so it was great excitement getting people moving around. There's nothing exceptional about the operating theatres. There is a hybrid room. There is perfusionist on site. Some of the bits that are less interesting are there's a PACU space, as you would expect in all centres, as we continue through the interventional radiology, and there are certain metrics that apply to their involvement as well as to the blood bank, into the surgical ICU. And every morning at 7 a.m. we have a trauma handoff, that is me, where we go through every patient on the list with all the residents, the day team, the night team, with our PI team. Other people beam in on Zoom. We have the floor, the ward staff, etc., so that everybody has eyes on what are the things that need to be actioned for those patients. This is our 20-bed trauma surgical intensive care unit, where I also attend as an intensivist. Each of the rooms is designed to be an individual room, to have family space, and to be an operating theatre if needed. The back right room is designated by the US Secret Service as the place for VIPs, should that be required, because they can put snipers on the two adjacent roofs. These are the regular wards, and again, we run one through the list with the nurses as well, to make sure that everybody is on the same page. And then people love to go up onto the roof and see the helipad. And as you can see in the picture, it's always sunny in Philadelphia. I have a tendency to get enthusiastic about this, so please shoot me down mid-sentence. I don't want to run over time. On my way here this morning, I passed by what used to be the Science Museum at the other university. And I remember distinctly that there was a big sign inside it, this Beckett quote about saying, "Ever tried, ever failed. Try again, and fail better." And really, that to me is the core principle in building a system and building a health system. This is incremental. You will not get it right first time. You will not get it right 100th time. We just need to get incrementally better. I took a picture of this on the ward. This is to illustrate it. We have one day without falls. It was great. We fail better in multiple different ways, one of which was last Friday, logged into our trauma MDT, where we have a very systematic way of going through the various patients. We do it within the trauma division. This is entirely separate from the Department of Surgery, M&M, and we go through with specific pieces in mind to make sure that there's guideline compliance and that we have the appropriate care and brought in the appropriate people. Not in any punitive way, but to figure out where are the holes in the system that we can fix. So I don't know, people in the summer games, in terms of cycling, this was identified as an opportunity for improvement when the Olympics were coming to London, because in the history of the modern games, they'd never won medal in cycling. And they hired this guy, David Brailsford, who had gone through the ranks in British cycling from a guy who owned a bicycle repair shop to being the coach of the team. And he had this notion of the aggregation of marginal gains. There are very few step changes that are game changers in surgery. But what we do is we do the little pieces, and we tweak the little pieces at the margins to make them better. If you do the maths of this, is compound interest, like we learned for our junior cert, and 1% better every day is 37 times better by the end of the year. No one thing made that happen. It was accruing little improvements. And identifying where the improvements should be. If you dig a hole in the wrong place, digging it deeper isn't going to help. So many of you are very familiar with Abraham Wald in Columbia University. He was a Jewish professor of statistics who in the Second World War, when it was unpopular in Europe to be Jewish, came to the United States. and he was part of the secret statistical research unit in Columbia University, which is essentially a cover for a military operation to figure out how to improve things. And this is the very famous paper that came out of his work, because the initial assumption was, when they looked at these damaged, I nearly said injured, but injured is appropriate in the context of today's talk, planes that came back to base, the mechanics marked out and they recorded in their ledgers all the different locations of the bullet holes. And they said, well, these are the places we're getting shot. These are the areas we need more armor to make our planes better. And he said, actually, no, the opposite is the case. You got to look at the planes that didn't come back. So this was really the genesis of survivorship bias. And so we need to look at not the things we did okay, but the things where there are catastrophic problems, there are things where there are a place where we can meaningfully improve things. For that, we need data. In my mind, clinical data like Lego, you can count it, you can sort it, you can present it with beautiful graphs. But to me, it's not that valuable unless you can explain it with the story. And so trauma systems in the States are not just to a single hospital, but they can be at state and national level. And they have various levels of oversight in order to nudge people to do the right thing. So you will all be familiar with PDSA cycles in terms of how you improve a process where you have to identify what the problem is. You say, okay, well, this is my strategy. Let's figure out what's actually happening now. Let's analyze that. Okay, this needs to be tweaked. We tweak that, and then we'll go again. And so how we do that in our acute care surgery and our trauma system specifically is our performance improvement. People attend our morning rounds, attend our morning report. Concurrently, they go through the charts with particular eye for particular details. Many deviations and so on can be dealt with immediately and tweaked in real time. But some things go on to case reviews and to this performance improvement meetings and an M&M conference. We also have trauma video review, which is exceptionally cool in that all the trauma bays and all our ICU beds have video cameras running all of the time with sound. There's like a bird's eye view and a one from the end of the bed. And we every month review trauma resuscitations. And it's not just about the technical skills, it's about how we're interacting, how we're making the team work efficiently. And we're starting to do that in our resuscitations in the ICU, and we're looking to do that in theatre as well, in terms of cases, in terms of the team dynamics. And there's so much you can do. You can learn from looking at the room that you don't get from the post hoc video that you see in Tom Walsh's video review in February. You need the context of what's happening in the room and how you motivate a room to get the best for your patient. We then work with Penn Trauma Network, which isn't just our hospitals, but other hospitals that have engaged with us to learn our systems. And we track and trend everything. These are just a couple of things that I fly through just to show that we keep some information. I keep quite a bit of information. So if I'm the reviewer, I will go through the chart and I'll come up with what happened with this patient. So this particular patient was multicavitary GSWs, and we look at what happened to the patient in terms of operatively, perioperatively, etc. We make sure they've gotten their antibiotics. That was major mass transfusion protocol initiated. Did we use whole blood? In our hospital, we have a cooler with whole blood in the trauma bay. So that's the start of our MTP, rather than having to wait for them to thaw out fresh frozen plasma, which by name and definition is frozen and takes at least a half an hour. So when you look at any of the literature, for example, on balanced one-to-one-to-one resuscitation, an obvious error in that is the fact that in almost everywhere you have to thaw the plasma, and therefore the only people who got balanced resuscitation are the people who got plasma who meant they were still alive at a half an hour. And so these kind of processes, we have to kind of look into this. We also have the ability to have a research student be on call 24/7. There's a panel of them, and they will attend every trauma and see what studies, clinical or basic science studies, this patient can be enrolled into. we capture a huge amount of information on our patients, because this is the power. This is how you get better, is knowing what you can improve on. And we track and trend delays to the operating room, unintended returns to the operating room, things like DVTs, etc. This makes for a much stronger system, and it allows us to iteratively improve our case management guidelines, which are, I know this is tiny and doesn't project, but just to give you that we have a list for a lot of different eventualities: blunt cerebrovascular injury, hemothorax, various features of how we can standardize and therefore improve our care. And I'm obviously happy to share relevant ones with you guys, should that be helpful to you. We also, on a national level, track where we are and compare ourselves to nationwide figures, and that allows us to find areas where we need to improve. And these are our ongoing projects in terms of improving documentation. The Troop study, which looks at our trauma exsanguination protocol and looks at ratios and looks at whether you do better if you get 2 units of whole blood and transition to the regular MTP versus keep getting whole blood, because there isn't an answer to that in the literature, as well as looking at our elderly population and frailty indices, looking at VT prophylaxis in terms of enoxaparin and whether trauma patients metabolize enoxaparin differently. And so we're now tracking all our patients with factor 10A levels to see whether they need to be dose escalated. Looking at our documentation, looking at metrics of time to imaging, time to IR involvement, etc. In the interests of time, and I'm very happy to talk about the analogs in emergency general surgery over a coffee, I kind of wanted just to finish up on time with saying that when you approach a new system, analogous to my dishwasher at the beginning, you can't, solving is for straightforward problems that have a logical solution. We can only do our best in taming wicked problems iteratively. And that the systems you build are the outcomes you're going to get. Trauma ACS volume without a system, all that does is produce unmanaged risk. We need to implement learning systems, and that's how we control our risk and bring the best outcomes to patients. And this infrastructure, and it does not necessarily physical builds, but infrastructure around brain power, etc., have to be intentionally built. Thank you for letting me drone on. I'm very happy to answer questions.
Thanks for opening the session. There's a trauma forum happening pretty soon, so we're keeping you busy for days, Gary.
That's quite all right.
Maybe time for a couple of points.